I have come up with very high-yield images for your anatomy. So let us discuss all those images one by one. Yeah, very good evening. Namaste. Assalamu alaikum. Walaikum salam. Good evening, Mithilesh. Good evening, Sumit. A very good evening to all of you guys. Fine. So we are going to discuss like very high-yield images, which are like definitely going to be asked in your exam. So without any further delay, let's get started right now, sir. Okay, no? Good evening. Good evening. Now, the first thing that I want to discuss here, my dear friends, now this transverse sections over here. Now, in your exams, what they're doing is they're actually giving this transverse section, and you have to just look at the transverse section and identify, okay, this is the transverse section of like brainstem, like the midbrain or the pons or the medulla oblongata. So now let us look at this first diagram over here, sir. In this diagram, like how to identify all these structures over here. Now, in this diagram, you're first of all able to see here, this is the aqueduct of Sylvius in the middle. And then on the dorsal aspect, you're able to find the colliculi. So therefore, these are nothing but your colliculi. You'll be having like two superior colliculi and two inferior colliculi on the dorsal aspect. And all together, all those four colliculi together, they are known as the corpora quadrigemina. And on the ventral side, you'll be able to find a fossa. That fossa is nothing but interpeduncular fossa. Interpeduncular fossa. Now remember, the aqueduct is a very important landmark. Why? Because whatever like area that we are able to see, whatever structure that you're able to see behind the aqueduct, that is known as the tectum. And the part in the middle here, this is known as the tegmentum part. And then this part is known as the cerebral peduncle. Understanding? So please remember that when you take a transverse section of the midbrain, it is actually divided into how many parts? Are three parts. That is tectum, tegmentum, and the cerebral peduncle. Okay, so behind the aqueduct, it will be tectum part here. And then this middle part over here will be tegmentum part. And this part in the front will be cerebral peduncle. Obviously, this has to be like cerebral peduncle and cerebral peduncle. That is the reason why in the middle, you are able to see a fossa that is known as interpeduncular fossa. Now one more thing, in the cerebral peduncle, you're able to see this dark area here, which is nothing but your gray matter that is known as substantia nigra. And then this white matter in the front of that is known as your crus cerebri. So by seeing all these features in the transverse section, yes, you're able to answer very clearly that this one is the transverse section of the midbrain. Now moving on to the next diagram over here. In this diagram, you're able to see all these important features, a beautiful butterfly shape over here. First of all, this structure here, which is present on the dorsal side, that is fourth ventricle. That is actually the fourth ventricle. And then in the front, you're able to see that there is olive. That elevation is known as what's a olive. And olive elevation is formed due to this nucleus that you're able to see here. That is inferior olivary nucleus. Please look at that beautiful shape of this nucleus. It is crumpled paperback shape. Inferior olivary nucleus, crumpled paperback shape. Now this elevation here is known as pyramid, and the pyramid is actually formed due to the tract which is passing from here. This is your pyramidal tract. And by seeing this, you can easily identify this one is a transverse section of medulla oblongata. So in your FMG exam, they have given these two sections. Yes, I hope now you'll be able to easily identify these images over here, sir. Now moving on to the next concept, next image. Wow. Nowadays, the most important one, that is about the development of the face. And in the development of the face, you have to be like very careful about the development of your upper lip and the lower lip, sir. First of all, try to understand this diagram. In this diagram, you're able to see this process here, that is mandibular process. And that mandibular process itself is going to form the maxillary process. Fine. And then this one here will be the lateral nasal process. And this is here the medial nasal process. And in the middle, you're able to find that there is a nasal pit there. So on either side of the nasal pit, there is a lateral nasal process and the medial nasal process, guys. Understanding? Now, my dear doctors, what is going to happen here? First of all, the mandibular process will fuse together. And the fusion of mandibular process will lead to the formation of lower lip. और अगर ये फ्यूज नहीं होगा, if it doesn't fuse, then it will lead to a condition known as midline cleft lower lip. The midline cleft lower lip is formed due to non-fusion of the mandibular process. It is formed due to non-fusion of the mandibular process. Now, similarly, how is this upper lip formed, sir? Upper lip will be formed by the fusion of maxillary process with the medial nasal process. Please be very careful here. It's not lateral, it's medial nasal process. The maxillary process with the medial nasal process together is going to form your entire upper lip. And now just imagine that if the medial nasal process does not fuse here, sir, ठीक है ना? If the medial nasal process does not fuse in the middle, of course it will lead to midline cleft upper lip. So midline cleft upper lip is formed due to the non-fusion of medial nasal process. The non-fusion of medial nasal process. Midline cleft upper lip. Suppose if there is a non-fusion of maxillary process with the medial nasal process, maxillary and medial nasal process, then it will lead to unilateral cleft upper lip. Unilateral cleft upper lip, sir. Then similarly, अगर मान लो दोनों साइड में भी फ्यूज नहीं होता है, if it is not fusing on both the sides, then it will lead to what? The bilateral cleft upper lip, sir. So non-fusion of both the maxillary process with both the medial nasal process, that is bilateral cleft upper lip. And then yes, one of the most important thing, अगर मान लो कि lateral nasal process यहाँ पर fuse नहीं होता है along with the maxillary did not fuse along with this lateral nasal process, then what is going to happen? It is further going to cleft above, and that is known as the oblique facial cleft. So the oblique facial cleft, I repeat again, it is due to the non-fusion of the maxillary process with the lateral nasal process, guys. I hope it's like crystal clear. So if you just follow this one diagram, everything will be like damn easy. Let's move on to the next slide now. And now, my dear friends, another very, very important concept, which is very much important for your FMG exam, the nerves related to humerus. And nowadays, what is happening? They're giving the questions in the form of radiological images, and the answer will be actually from the anatomy part. Okay. So for example, this radiological image is given over here, and there is an arrow mark, and there is a fracture in this region. You can clearly see that is nothing but surgical neck fracture. Which nerve can be most commonly injured here? Axillary nerve. Similarly, what is the nerve injured in the fracture of shaft of the humerus? You know very well what is the nerve passing behind the shaft of the humerus over here. That's your radial nerve. So therefore, radial nerve will be gone. And this was a recently asked question in your MC exam, sir. Then after that, suppose if they give you the image in this manner, you can clearly see this is the lower end of the humerus, the lateral epicondyle and the medial epicondyle here. Why? Because this side you can see the ulna, and ulna is actually having that olecranon process. With the help of that, you can easily identify, okay, this is the medial side. So ulna on the medial side, the radius on the lateral side here. So if there is a fracture of medial epicondyle, then it will lead to the nerve which is involved will be the ulnar nerve. Fine. So I hope you all remember from our classes, okay, our videos of, Dr. Tutorial and even our offline classes. You can remember I have given you this diagram. Not even just giving this diagram, we have actually drawn this diagram. So what is the nerve which is going to pass behind the surgical neck of the humerus? Axillary nerve. What is the nerve passing behind the shaft of the humerus in the spiral groove? That is radial nerve. And then what is the nerve which is going to pass behind the medial epicondyle? That is your ulnar nerve. I hope you'll be able to answer this question now, sir. Are you understanding me? Moving on to the next one now. Now, in the joints, I hope you all know the joints are actually divided into three categories, sir. You'll be actually having the fibrous joint, that is immovable joint, and then the cartilaginous joint, which is partially movable joint, and the synovial joint, which is like completely movable joint, sir. Now, in the very first diagram here, this is the radius and the ulna, and this one is the middle radio-ulnar joint. And that middle radio-ulnar joint is formed between the radius and ulna with the help of this interosseous membrane. Interosseous membrane. And this type of joint, which is formed between the two bones with the help of interosseous membrane, that joint is known as the syndesmosis. It is immobile joint. When it comes to the superior and inferior radial joint, now these two joints, that is superior and the inferior radial joint, will be the movable joint, and they are like belonging to the subtype of pivot joints. So they're actually helping in pronation and supination, pivot joint. So this will be actually the pivot joint here, and the middle radial joint will be syndesmosis. That's an immovable joint, sir. Now, similarly here in this diagram, the next diagram, this has been like repeated multiple times in the FMG exam. Yes, this image is given and there is an arrow mark, and the arrow mark is on pubic symphysis. I hope you remember from our regular classes, I taught you that the joints which are in midline, that is the important word, midline, those will be the secondary cartilaginous joints. The joints in the midline will be the secondary cartilaginous joint, and this is pubic symphysis. Of course, it is a secondary cartilaginous joint, sir. And what is the another name of that one? It is symphysis. The secondary cartilaginous joints, also known as symphysis, and the examples you can remember that very easily. Just remember midline, sir. So, for example, the joint between the manubrium sternum and the body of the sternum, manubriosternal joint, and then xiphisternal joint, intervertebral disc, pubic symphysis, the joint between the sacrum and the coccyx, all the midline. But remember, except the symphysis menti. This is the mental part of the mandible, the symphysis menti. That is not a secondary cartilaginous joint. That is a special category of the fibrous joint, sir. Is it okay? So in joints, I want you to remember these two important images, sir. I repeat again, once for the last and final time, the middle radio-ulnar joint here will be the example of syndesmosis. It's an immobile joint. And the pubic symphysis here is an example of secondary cartilaginous joints. Moving ahead with the next concept. Wow, dermatomes. Like, many of the students have been sending the messages, sir, how to remember dermatomes, how to remember dermatomes. यार, इससे आसान कुछ नहीं है, मैं आपको कहता हूँ ना. It's very, very easy. I'll tell you how to remember. You people have studied like brachial plexus along with me a lot of times. ठीक है ना? And brachial plexus is going to originate from where? From C5, C6, C7, C8, and then T1. And those nerves are actually going to supply to the particular region of the skin, dermatome. तो इसको पढ़ने का तरीका ये होगा, just start from the lateral side. If you're able to see my upper limb over here, just start from the lateral side. This one here, C5, and then your thumb here, C6. The middle three fingers, not the middle finger only, middle three fingers, index, middle finger, and the ring finger, these three. Okay, that is C7, and then little finger, that is your C8, and then come back here on the medial side, that will be T1. So you can just see in this diagram here, you can have to just go from the lateral side and come towards the medial side over here. So C5 hoga, thumb will be C6, middle three fingers will be C7, this is C8, and this one here will be the T1. That's all. That's all. Now they'll ask you in the exam, what will be the dermatome of thumb? It's C6. What is the dermatome of the index finger? C7. What is the dermatome of little finger? C8, something like that. Understanding? So it's so simple. Just remember, brachial plexus is the one which is going to supply to your upper limb. So therefore, my dear doctors, remember that, yes, C5 to T1, you have to just go in this manner. Now, when it comes to lower limb, sir, in the lower limb, I'll tell you one interesting thing here. If you want to listen here, my dear friends, upper limb and lower limb during development, they'll actually rotate, and upper limb will be rotating externally like this. So therefore, the thumb will be going towards the lateral side. But in the lower limb will rotate medially. So therefore, the great toe will come on the medial side. It is rotating like this here, and that is rotating in this internal manner. So therefore, because of that internal rotation, you just keep on going ahead like that. And what is the plexus which is going to supply to the lower limb? Lumbosacral plexus. So चलिए sir, start करते हैं. So L1 here, then L2 here, then L3 here. I told you, keep on rotating towards the medial side. So L1, L2, L3, then L4 here, then L5 here, sir. Understanding here? So therefore, lower limb, anterior view. Anterior view, it is all lumbar, L1 to L5. Fine. Now remember, up to knee joint, from in the entire thigh, sir, up to the knee joint, it will be L1, L2, L3. Up to the knee joint, it will be L3. And then after that, L4 on the medial side of the leg, L5 on the lateral side of the leg. And this was given as an arrow mark in your FMG exam. On the medial side of the leg, what is the dermatome? That is L4. Simple. So just keep on going like this, medially rotating. So L1, L2, L3, then L4, then L5. That is on the ventral side. Then on the dorsal side, what is going to happen? You'll be having the remaining sacral dermatomes. Okay, now, so there is like S1 over here, then keep on going up, there will be S2 here, then keep on going up, there will be S3, S4, and then there'll be S5 here. We also discussed about that S2, S3, S4 along with the pudendal nerve. Pudendal nerve, मैंने आपको बताया था saddle anesthesia and all those things, है ना? So that is how you can easily remember these dermatomes here, sir. Okay, so on the ventral side, on the front view, there will be L1, L2, L3 up to the knee joint, then L4 on the medial side, L5 on the lateral side in the leg. And then on the dorsal side, we'll be having S2, just go back. Okay, so S1, S2, then S3, S4, and S5 will be along the or around the perianal region. Perianal region. Is it okay? Next one, sir. Wow. This sagittal section, normally we have learned in the anatomy wala images, but nowadays what they're doing is they're actually giving you in the radiological image and you have to identify them, sir. Fine. So let us try to identify all the structures over here. I hope everyone knows the largest commissure. This one here will be the corpus callosum. Simultaneously, please recall what are the four parts of the corpus callosum. There will be rostrum, genu, body, and the splenium. I repeat again, rostrum, genu, body, and this is the splenium part. And just below the corpus callosum, there will be actually a septum. In between the two lateral ventricles, there'll be a septum known as septum pellucidum here. And that septum pellucidum, the lower border of that septum pellucidum will be attached towards a fornix. So lower border of the septum pellucidum will be attached with this structure, that is fornix. Very, 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 very important to remember. Has been asked many a times in your exams. And after that, everyone can easily identify this one is the midbrain. After the midbrain, that big bridge-like structure will be pons. And after the pons, this one will be the medulla oblongata. Now, the important thing, what do you have right in front of the midbrain? In front of the midbrain, this structure is infundibulum. You can clearly see that is getting attached to what? The pituitary gland. Okay. And this shiny one that you can see here behind, that is the posterior lobe of the pituitary gland, sir. So this is infundibulum. And then the next one, this is of course your pituitary gland over here. And then this body here, that is your mammillary body here, sir. And after that, my dear friends, these are all the structures which are like very much important to remember in this one. You're able to see again the same thing, the aqueduct, the third ventricle over here, the fourth ventricle over here, and this is the cerebellum. Those structures you can easily identify. So whatever I have marked here, please try to identify those structures very, very clearly in the exam. You should be perfect with the fornix, infundibulum, and the mammillary body. These three are very much important for your exam, sir. Now, after the sagittal section, let us move on to the transverse section. In the transverse section, this picture has been repeatedly given in your FMG exam, sir. Now, in this one, let us try to first of all identify the components of basal ganglia here. Now, this nucleus is the caudate nucleus, and this one here will be the thalamus. And then on the lateral side, you'll be able to find that lentiform nucleus. Lentiform nucleus has been asked in your exams a multiple number of times. And I hope all of you know that very well. Lentiform nucleus is the one which is made up of two more nuclei, that is the putamen and the globus pallidus. अच्छा, इन सब के दरमियान में क्या होता है? What do you have in between them? This is nothing but your internal capsule. That is internal capsule, sir. So what do you have on the lateral side of the internal capsule? There'll be lentiform nucleus over here. And then what do you have on the medial side? There'll be caudate nucleus and the thalamus over here. And I hope you all know the important points regarding internal capsule. Let us quickly recap. How many parts do you have in the internal capsule? There are like 5 parts. Anterior limb, the posterior limb, the bent in the middle will be the genu, and then retrolentiform part and the sublentiform part. These are the 5 parts of the internal capsule. Then even remember the 2 important tracts which are going to pass through the internal capsule. What is the tract which is going to pass from the genu part here? That is cortico-nuclear tract. And similarly, from the anterior 2/3 of the posterior limb, I repeat again, anterior 2/3 of the posterior limb, there will be corticospinal tract passing from here. That's your favorite one. That is your pyramidal tract, sir. So corticospinal tract is going to pass from the anterior 2/3 of the posterior limb, sir. And after that, one more important thing, what is this hidden lobe over here? This lobe will be the insula. Insula. You got to remember all the structures for your exam, sir. Moving on to the next image now. Now, now, my dear doctors, the next image that we are going to discuss here, yes, even this image was also given in your exam. And this image, you can see the site of lesion here. And exactly contralateral side, there will be loss of pain and temperature. That means contralateral side, there is loss of pain and temperature. Ipsilateral side, there will be loss of vibration, position sense. That is nothing but conscious proprioception, stereognosis is lost. And this indicates your Brown-Sword syndrome. So this image was given in the FMG exam, and you actually have to identify this syndrome. So contralateral loss of pain and temperature, ipsilateral loss of fine touch, vibration, stereognosis, and the conscious proprioception, that indicates it's a Brown-Sword syndrome. So you have to be like well aware of this image here. I hope you are quickly getting all the images, my dear friends. So these are like very, very high-yield images of anatomy. We have discussed the entire concept in details in the videos of doc tutorial. Entire anatomy we have discussed, but right now we are just quickly going through all the images so that you can even watch this video just before going to your exam, so that you can just quickly see all the images here, sir. Fine. Now, another hot favorite concept. This H-shaped suture here will be Tyon. And Tyon is formed between the 4 bones. This one here will be the frontal bone. And this here will be the parietal bone. This here will be the temporal bone. And of course, the squamous part of the temporal bone. And this part here will be the sphenoid. And that is the greater wing of the sphenoid. So the suture, that is H-shaped suture, that is Tyon, is formed between these 4 bones. Now, Now, what is important here, recently in the July MC exam, what they have asked is if there is a hit in this Tyon wala region, then which type of hemorrhage will occur? That is nothing but epidural hemorrhage. And you can easily identify that epidural hemorrhage with that, idly shape, biconvex shape. There's so many names the students have given to this one. I hope you'll be able to identify. So this is epidural hemorrhage or extradural hemorrhage, and due to the hit in the Tyon. Apart from this clinical application, they're also asking what are the deep relations of Tyon. So please remember this one here. Number one, there will be anterior or frontal division of middle meningeal artery. And then, of course, there will be sylvian fissure, lateral sulcus of the cerebrum. And inside the sylvian fissure, you'll be actually having the middle cerebral vessels. I hope you're getting all the points very quickly, sir. These are all the deep relations of Tyon, just present deep to the Tyon, sir. Next one. Muscles of tongue. Take my words, one question will definitely come from the tongue topic, sir. Tongue topic से एक सवाल आपके एग्जाम में पक्का आएगा, definitely. Now let us see all the extrinsic muscles of the tongue, sir. Number one, this muscle here. Yes, of course, it was given as an image-based question in your exam, and you have to identify this muscle, and this muscle is genioglossus. And genioglossus, remember 2 points. Number one, it is the largest muscle of the tongue. And number two, it is the safety muscle of tongue. Why? Because genioglossus is the one which is going to prevent the falling of the tongue back. It prevents the falling of the tongue back, and it is going to keep the tongue a little forward, helping in protrusion of the tongue. So that is why it is known as the safety muscle of the tongue, sir. Now this muscle, which is coming from the styloid process, you can very clearly see here, this is the styloid process, and it is coming all the way from here, going to the tongue. And this muscle here will be styloglossus muscle. And this muscle here is actually coming from the palate into the tongue, palatoglossus muscle. And from the name itself, we can easily remember that it's a muscle of the palate as well as the muscle of the tongue. So therefore, my dear friends, it is not a true muscle of the tongue. It's not a true muscle of the tongue. Then this muscle here, which is coming from the hyoid bone into the tongue, that is nothing but hyoglossus. Okay, so please try to remember all these extrinsic muscles of the tongue, sir. और इसको याद रखने का तरीका बड़ा आसान होता है, आगे, पीछे, ऊपर और नीचे से. That's all. You're done. Genioglossus, styloglossus, palatoglossus, and then the hyoglossus. Okay. Achha, by the way, like what is a nerve which is supplying to all the muscles of tongue? All the muscles of tongue will be supplied by 12th cranial nerve, hypoglossal nerve, and remember, except the palatoglossus. And palatoglossus will be supplied by vago accessory complex. It is supplied by vago accessory complex, palatoglossus. Fine. Now, how to test this hypoglossal nerve? You are going to ask the patient to protrude the tongue, and the tongue is deviating towards the left side. It means the left side genioglossus muscle is gone. It means the left side hypoglossal nerve is involved, sir. तो hypoglossal nerve को टेस्ट करने के लिए क्या करना पड़ेगा? Ask the patient to protrude the tongue. If the tongue is deviating towards the left, that means left side 12th nerve will be involved. And please don't forget to learn about the sensory supply of the tongue and how to remember the sensory supply of tongue. I taught you a lot of times, my dear friends. Remember, it is remembered as 5, 7, 9, 9, 10, 10. 5, 7, 9, 9, 10, 10. Anterior two-third special sensation by 7th nerve, chorda tympani branch. Anterior two-third general sensation by 5th nerve, trigeminal. Which branch? Lingual branch of the mandibular nerve of trigeminal. Posterior one-third is very simple. General and special will be carried by 9th nerve, and posterior most part, both general and special will be carried by the 10th nerve. That is your vagus nerve, sir. I hope you remember that very well. I taught you many a times that one. And this one I have included here. Why? Because yes, very, very important topic. 1 mark, 1 mark आपके exam में definitely आएगा. One question from here, from the tongue topic, sir. Now, another very important thing. Yes, I hope the moment you look at this diagram, now you're able to easily identify ectoderm will invaginate to form the ectodermal clefts, and the endoderm will actually evaginate to form the endodermal pouches. Now, there are 4 ectodermal clefts and the 4 pouches. Now, first, let us start with the first ectodermal cleft. It is going to form external acoustic meatus along with the outer layer of tympanic membrane. Whereas the second, third, and the fourth cleft will be completely obliterated, nothing forming from there. Okay. And sometimes what will happen, this space which is formed here is known as cervical sinus. And cervical sinus has to be normally closed. As you can see in your body and my body right now, it is completely closed. In some people, unfortunately, it persists. And if it is going to persist, it will lead to a branchial cyst or the branchial fistula over here, sir. Okay. Now moving on to the endodermal pouches, there are totally like 4 endodermal pouches. The first pouch is going to form the middle ear cavity along with the auditory tube, along with the inner layer of tympanic membrane. Second pouch is the one which is going to form palatine tonsil, but remember not the entire palatine tonsil, of course, it is going to form the epithelium of the palatine tonsil. The third pouch, remember with the rhyming word thymus. Third pouch is going to form thymus. Along with the thymus, it is going to form inferior parathyroid gland. Remember inferior. क्योंकि यहाँ पर thymus form होता है. After the formation of that, it has to actually go down, migrate down into the mediastinum. So because it is going to migrate down into the mediastinum, along with that, it is going to form inferior parathyroid gland cell. And then the fourth pouch is the one which is going to form superior parathyroid gland, guys. Clear? So you have to be perfect with the ectodermal clefts and the endodermal pouches. Can anyone please answer me in the chat box there कि DiGeorge syndrome में कौन से वाले pouches involve होते हैं? Which pouches are involved in the DiGeorge syndrome? Can you just answer in the chat box? Remember the third and the fourth pouch. These two pouches are actually involved in the DiGeorge syndrome. That is the reason why thymus gland will not be formed, leading to thymic hypoplasia. And along with that, parathyroid gland is not formed. So therefore, calcium cannot be regulated. It will lead to hypocalcemia. Hypocalcemia. Next one. The next concept, I hope the moment you look at this diagram here, you're easily able to understand this is nothing but your brachial plexus. And in brachial plexus, how many trunks do we have? So you'll be having like 3 trunks: upper trunk, the middle trunk, and the lower trunk. So if there is an injury to upper trunk, that will lead to what? It'll lead to Erb's paralysis. And you know what is going to happen at the arm? Arm will be adducted and medially rotated. Elbow will be extended and the forearm will be pronated and the fingers will be actually flexed here. So I repeat again, arm will be adducted and medially rotated, elbow will be extended and the forearm will be pronated and the fingers are flexed. That will give the appearance of a policeman's tip hand, also known as the waiter's tip hand, also known as the porter's tip hand. If there is an injury of the lower trunk, that will lead to Klumpke's paralysis. And Klumpke's paralysis, it will be claw hand. Or claw hand कैसे form होता है? There is a hyper extension at metacarpophalangeal joint and then there will be flexion at interphalangeal joints. Hyper extension at metacarpophalangeal joint, flexion at interphalangeal joint, that will lead to Klumpke's paralysis, claw hand. Then if the long thoracic nerve is gone, it will lead to winging of scapula. Injury to the long thoracic nerve will lead to winging of scapula. Which muscle will be paralyzed here? That is your serratus anterior muscle will be paralyzed. And you just ask the patient to push something. You can see the scapula bone will become like more prominent. And that to which border of the scapula becomes prominent, sir? The medial border of the scapula becomes more prominent. Next concept. Anatomical snuff box. How can you forget this one? They'll definitely ask you like one question from the anatomical snuff box. Yes, you know very well what are the boundaries of the anatomical snuff box, sir. On the on the lateral side, there'll be actually 2 tendons. On the lateral side, there'll be like 2 tendons. One will be abductor pollicis longus. Another one is extensor pollicis brevis. Then on the medial side, there'll be only one tendon, that is extensor pollicis longus tendon. Now, what is the content of anatomical snuff box? Everyone knows that very well. It is only the radial artery. But nowadays, the most important thing is they're giving you a clinical question in which a person actually falls on the outstretched arm and then complains about the pain in anatomical snuff box. It is due to the fracture of which bone? So you know very well, in the floor of the anatomical snuff box, there will be scaphoid and the most commonly fractured carpal bone, scaphoid. So because of the fracture of scaphoid, there'll be a pain in the anatomical snuff box if a person falls on outstretched arm. Very, very important concept. We are done with the boundaries, we are done with the content, and we are done with one of the clinical application over here. The pain in the anatomical snuff box is due to the fracture of scaphoid, which is lying in the floor of that one, So next one. The next concept is about the attachments on the femur. Another very, very important concept. You are able to see this diagram here. That is nothing but the front view. In this diagram, first of all, this is anterior superior iliac spine. And here there'll be attachment of number one, there'll be a ligament, that is inguinal ligament. And apart from that, there is a muscle, that is sartorius muscle, your favorite one, the longest muscle in our body, and also known as the Taylor's muscle, also known as the honeymoon muscle. Beneath this, you'll be able to find the anterior inferior iliac spine, and there is attachment of rectus femoris. Rectus femoris is one of the head of quadriceps femoris. Then in this diagram, you're able to see this is the greater trochanter. Attached to the greater trochanter will be the gluteus minimus in the front view. Now, similarly, if you see the back view, in the back view, again the same thing, the greater trochanter will be attached with gluteus medius. So gluteus medius and the gluteus minimus, both of them will be attached onto the greater trochanter. But remember, gluteus minimus will be attached in the front view, whereas the gluteus medius will be attached in the posterior aspect. And both the muscles are actually helping in abduction at the hip joint as well as internal rotation, which was given in one of the exams recently, gluteal tuberosity. And here there'll be attachment of gluteus maximus muscle. And gluteus maximus muscle is helping in extension at the hip joint along with external rotation. So in MC exam, this was given lesser trochanter. And lesser trochanter, two muscles will be attached there, iliacus and the psoas major. And some of the authors will mention this one as iliopsoas muscle will be attached onto the lesser trochanter. So fine. Now, apart from this, one of the most important concept nowadays, this spine here, that is your ischial spine. And there are like three structures which are going to take a turn around the ischial spine. And those three structures we remember as pin structures. We are going to remember as pin structures. And what are the structures going to take a turn over here? Number one, pudendal nerve. Number two, there will be internal pudendal artery and vein. And along with that, the nerve 2 obturator internus is going to take a turn over here. So the question that is asked in your exam is, what is the nerve which is going to take a turn around the ischial spine? Which nerve turns around the ischial spine? Of course, that is your pudendal nerve. Pudendal nerve is going to take a turn. And one more important thing regarding this one is, this is the site of pudendal nerve block. So what is the site of pudendal nerve block? That is nothing but your ischial spine. Ischial spine, sir. Take it. Now, after that, yes, in your exam, as I'm telling you again and again, they're giving the image, radiological image, and then they're asking the question, anatomy. The question is actually from the anatomy part, but the image is actually from the radiology part, sir. So this image was given, X-ray over here, and you can see the arrow mark was on the lesser trochanter, and they've asked like what is going to be attached onto the lesser trochanter. So please remember that. Yes, of course, it will be iliacus muscle and the psoas major muscle, sir. There'll be iliacus and psoas major muscle attached onto the lesser trochanter. Now, very, very famous concept. The moment you look here, I hope you're able to understand here. It is nothing but lurching gait. And in the lurching gait, the nerve involved will be the superior gluteal nerve. And superior gluteal nerve is the one which will be supplying to gluteus medius and the gluteus minimus. The gluteus medius and the minimus are gone. You're not able to abduct the pelvis. So therefore, you're going to lurch the body on one side and walk. Lurching gait, Trendelenburg sign will be positive in this one here, sir. I repeat the 4 points again here, sir, quickly. Trendelenburg sign is positive in this one. There's nothing but lurching gait. In the lurching gait, nerve involved will be superior gluteal nerve supplying to gluteus medius and the minimus. Next one. Now, the next concept, tarsal tunnel. Now, it is very, very important, sir. Now, first you have to remember what are the structures passing in the tarsal tunnel here. Number one, this tendon here will be tibialis posterior one. Now, this tendon here will be the flexor digitorum longus. And then after that, you're able to see the artery there. That artery is nothing but the posterior tibial artery. Just behind that posterior tibial artery, you'll be able to find the nerve, that is your tibial nerve. And then again, there's a tendon here, that is flexor hallucis longus tendon. Flexor hallucis longus tendon. I hope you remember that very famous mnemonic. How to remember this one, sir? Tom, Dick and Harry. Tom, Dick and Harry. मैंने classes में आपको बताया था. Now, in your exam, the question is like, they're giving this image. In this image, the doctor is trying to, yes, see the peripheral pulse. And in that peripheral pulse, that peripheral pulse here will be measured by which artery? That artery is nothing but the posterior tibial artery. So with the help of this posterior tibial artery, you're able to measure the peripheral pulse over here. So that's important. Let us move on to the next concept. I have given you this image over here. Why? Because this was like, repeated for like 2-3 times in your exam. You should know about the tarsal bones. How many tarsal bones do we have? We have totally like 7 tarsal bones, and you should be able to again identify in the radiological image over here. There'll be first of all like 3 cuneiform here. On the lateral side, there'll be cuboid. and this boat-shaped one, navicular, and that is right in front of the talus, and this big heel bone over here will be the calcaneus. So calcaneus, and then above that there'll be talus, in front of that navicular, on the lateral side cuboid, and then the three cuneiform. So this is how you should be able to identify all the tarsal bones over here, sir. Okay, now. Then after that, yes, this planes. Nowadays they're asking these planes, and nowadays they're asking these planes, and in these planes you actually have to remember like they are at which level, sir. Transpyloric plane, it's present at the level of L1. Subcostal plane, touching the lowermost part of the costal margin, that is at the level of L3. Supracristal भी होता है यहाँ पर ना. This is actually the crest of the iliac bone. Supracristal bone, that is plane at the level of L4. And then intertubercular plane or transtubercular plane will be at the level of L5. I repeat again, transpyloric plane at the level of L1, subcostal L3, and then supracristal, that is L4, and then intertubercular or transtubercular plane, that is at the level of L5. Remember, umbilicus will be between the L3 and L4, sir. Okay, and remember the dermatome of the umbilicus is T10. Don't get confused between the location of the umbilicus and the dermatome, sir. Okay, umbilicus will be present between L3 and L4, and yes, the dermatome of the umbilicus will be T10 here, sir. Okay, next one, sir. The journey to become a doctor. Sir, you are great. Thanks for making anatomy and biochemistry easy. Thank you, doctor. Thanks for appreciating my hard work. Multi-star, wow. Sir, also teach us ortho. Oh my God. Let's go ahead now. I think this revision is going good, right? Yeah. So I'm not going to completely waste your time over here, sir. Like even just before the exam, like one day before the exam, you can watch this video at 2x. मैंने फटाफट सारे इंपॉर्टेंट इमेजेस यहाँ पर इंक्लूड कर दिए हैं, तो जस्ट एग्जाम से पहले इस वीडियो को देख लेना आराम से 2x पर, तो फटाफट ना सारे इमेजेस एनाटॉमी वाले रिवाइज हो जाएंगे. आई होप दैट शुड हेल्प यू, है ना. Next concept here, so openings of diaphragm. How can you forget that? There are three major openings in diaphragm, and we remember that as voice of America. Now, this opening that you are able to see in the central tendon, sir, that is vena cava opening, and vena cava opening will be at the level of T8. And what is going to pass from here? Of course, inferior vena cava, but forget about that one. Remember, right phrenic nerve is passing from here. Next opening, this one here is esophageal opening. In this muscular part, you're able to see the esophageal opening. Esophageal opening will be at the level of T10. And what is going to pass from here? Of course, esophagus. But forget about esophagus. Remember, along with that, vagus nerve is passing from here, sir. After that, this opening here, which was recently asked in the FMGE exam, this opening is actually the aortic opening, sir. An aortic opening will be at the level of T12, and passing from here will be the aorta, the thoracic duct, as well as the azygous veins. So you should remember their levels T8, T10, and T12, and what are the structures passing from this one here. Okay. And then one more important thing is about the development of diaphragm. They're actually giving this image in your exam. The moment you see this image, you can clearly see the intestinal loops have herniated into the thorax. The loops of intestine have herniated into the thorax. So this is actually indicating congenital diaphragmatic hernia. Fine. The moment you see this one, it is congenital diaphragmatic hernia. आपने पहचान लिया. But remember the reason why. Why it is happening. What is the reason for that one? So remember, pleura and the peritoneum. There is a pleuroperitoneal membrane. Pleuroperitoneal membrane. And that pleuroperitoneal membrane will be absent. And absence of this pleuroperitoneal membrane, what is going to happen? It'll lead to congenital diaphragmatic hernia. So please remember, the congenital diaphragmatic hernia is due to absence of pleuroperitoneal membranes. Next concept. Neural tube. Definite question in your exam, sir. So first of all, this is your neural tube here. And neural tube is the one which is going to form your central nervous system, that is your brain and the spinal cord. Now this is the cranial neuropore, and this one here will be the caudal neuropore. The cranial neuropore will be closing on 25th day. After 2 to 3 days, that is 27th or 28th day, the caudal neuropore will close. I repeat again, the cranial neuropore will close on 25th day. The caudal neuropore closes on 27th or 28th day. अगर दोनों भी option दिया जाएगा, the more better option will be the 28th day, sir. Is it okay? After that, suppose if the cranial neuropore does not close, it will lead to a condition known as anencephaly. Anencephaly, there's no formation of the cranium, no meninges, the brain will also be exposed outside. And then if the caudal neuropore does not close, it will lead to spina bifida. Spina bifida. But remember one more important thing here. Anencephaly hoga, and that is actually continuing behind. And behind, there is a deformity of the spine also. Spines will not be formed there. So therefore, that condition is known as the craniorachis. That is known as craniorachis. That was given in the recent exam. Remember that one. So moving on to the next one. One question definitely will be coming from the neural tube topic, sir. Please remember that one. Is it okay? Next concept now. Now, dropped shoulder. Can you see here? This shoulder is actually dropped here. And dropped shoulder, it is due to the paralysis of which muscle? Trapezius muscle. Trapezius muscle जब contract होता है, the trapezius is actually going to help you in shrugging of the shoulders. Shrugging the shoulders. If trapezius is gone, then what will happen? Forget about shrugging of the shoulder. That shoulder will be actually dropped. So in dropped shoulder, which muscle will be involved? Trapezius muscle is involved. And trapezius and sternocleidomastoid, आप सबको अच्छे से पता है, that will be supplied by spinal accessory nerve. Trapezius and sternocleidomastoid will be supplied by spinal accessory nerve. 11th cranial nerve. Remember that one. So in this given image, what is the nerve involved? Spinal accessory nerve. Which muscle is gone? That is your trapezius muscle is gone, sir. Next concept is about the Umbilical Seal. I hope you all remember about rotation of gut. Can you please answer me in the chat box there? कि foregut rotate होता है कि नहीं होता है? Foregut will rotate or not? Yes, of course, the foregut will rotate. How much? It is going to rotate 90 degrees in the clockwise direction. What about the midgut? Midgut will rotate 270 degrees in anti-clockwise direction. Fine. And finally, about the hindgut rotate nahi hota hai. So midgut rotation will be 270 degrees in anti-clockwise direction. And that to remember, the midgut will be actually herniating out from the umbilical opening. So can you please tell me here, is this like physiological hernia or pathological hernia? Is this physiological hernia or pathological hernia, sir? It is physiological hernia. And please remember, my dear friends, physiological hernia will occur by 6th week. And a reduction of physiological hernia will occur by 10th week. Physiological hernia will occur by 6th week. Reduction of physiological hernia will occur by 10th week. Okay, now. So thank God that, our midgut, it came out, rotated and went back inside. Very well. Our abdomen is perfect right now. But there are some unfortunate babies. In them, what will happen? The midgut will come out, but it will fail to reduce back. It will fail to reduce back. When the midgut will fail to reduce back, that baby will take birth with all the coils of intestines lying outside, and that is covered with that, peritoneum. So this condition is known as what, sir? Omphaloseal. इसको हम omphaloseal कहते हैं. I repeat the important points again. When will physiological hernia occur? 6th week. When will the physiological hernia reduce back? By 10th week. And if it doesn't reduce back, that condition is known as omphaloseal. So be ready for this type of image-based question. तो इमेज देखते ही आपको पहचानने आना चाहिए कि it is actually omphaloseal over here, sir. Next concept, and nowadays hot favorite concept. Again, you can actually expect one question from here definitely in your exam, sir. That is straddle injury. And we have discussed this very nicely in our offline classes also. And in detail, I have discussed this in the doc tutorial videos also. As well as I have actually discussed about the extravasation of urine on the doc tutorials YouTube channel also. You can go and watch there. And I'm telling you, it will be worth spending your time. Hardly, I think there is a video of 25 minutes or 30 minutes video only on extravasation of urine completely. Okay. And if you watch that video, my dear friends, I'm telling you, definitely 1 mark. It is worth watching. 25-30 minutes कभी भी YouTube चैनल पर डॉक ट्यूटोरियल्स YouTube चैनल पर मैंने ऑलरेडी ये वीडियो किया है. आप जाकर एक बार ना देखना ध्यान से. Now, what is the straddle injury? Yes, riding the bicycle on the bumpy road. Riding a bicycle on the bumpy road. Okay. And number 2, the fall of a man in the manhole. A man falls in the manhole, something like that. Okay ना? तो इसमें क्या होता है? इसको हम straddle injury कहते हैं. And my dear doctors, in this, the bulbar urethra will be ruptured. And when there is a rupture of bulbar urethra, जब bulbar urethra rupture हो जाएगा, the urine will go out into, number 1, superficial perineal pouch. Number 2, the urine will go into the scrotum. Number 3, the urine will go into the penile shaft, and the urine will also go into the anterior abdominal wall. एंड दिस इज ड्यू टू द रप्चर ऑफ विच यूरेथ्रा, बल्बार यूरेथ्रा। और ये कब रप्चर होता है? इन दिस कंडीशंस ऑफ स्ट्रैडल इंजरी हियर सर, स्ट्रैडल इंजरी होता है। तो प्लीज रिमेंबर दिस कॉन्सेप्ट वेरी वेरी नाइसली माय डियर फ्रेंड्स। डेफिनेट क्वेश्चन विल बी कमिंग फ्रॉम हियर सर, डेफिनेटली वन क्वेश्चन विल कम फ्रॉम हियर। Is it okay? Fine. Thank you, Anand Kumar Gupta. Thank you so much for making anatomy and biochemistry so easy. Lots of love from Bihar. Love you too, brother. Thank you. Now, that is an important concept. Please remember that one, sir. Is it okay? So that's all, my dear friends. That is about all the high yield images, very, very high yield images. These images are like must know, should know before going to the exam. So make sure that you're not going to go to the exam without going through all these images. Very much important. And I have done this in the shortest time possible. Please look at this video again just before going to the exam, like on 2x पर इसको ना ध्यान से देखना और सारे images आपके यहाँ पर ना रिवाइज हो जाएंगे. And I think that will help you a lot in your exam, sir. ठीक है ना? So all the best to you people. Like God bless you all. Yes, you can clearly see on the screen my WhatsApp number and my Instagram handle. You can always communicate with me at these two places. And one more important thing, yes, I have created a Instagram channel also with the same name, Dr. Azam Lectures, and even WhatsApp channel also. And there I'll be posting like questions daily. So try join there and share with all of your friends so that it will help all of us. Why? Because together we can achieve. All the best. Take care. Thank you. God bless you.